All right, let's dive right in. We're going to break down the brand new 2023 British Thoracic Society Guidelines for managing spontaneous pneumothorax. And trust me, this is a huge update, really critical stuff for your day-to-day practice, and definitely for anyone prepping for specialty exams. So first things first, this whole explainer is based on the fantastic summary work of Dr. Mohammed Al-Nagi Mohammed. We're going to walk through the key changes here, the stuff that's actually going to change how you assess and manage these patients from the moment they walk in the door. Okay, here's the plan. We'll kick things off with the big philosophical shift in the guidelines. Then we'll get practical with the new symptom-first algorithm. After that, we'll talk about how to spot those high-risk patients, what our options are for intervention, and we'll wrap up with some crucial discharge advice that has changed a lot. So let's get to the heart of it. What is the single biggest change here? Well, the new guidelines have basically flipped the script on how we approach these patients right from the get-go. You know how it used to be, right? We'd all get our rulers out and measure the pneumothorax on the chest x-ray. That size dictated everything. Well, the 2023 update says, hold on a second. The new focus is all about the patient's clinical state. It's about their symptoms, their risk factors, not just some measurement on a film. So how does this actually work in practice? Let's break down the new algorithm. This whole symptom-first idea really boils down to one simple, central question that you have to ask right at the start of your assessment. And that question is simply, is the patient symptomatic? That's it. That is the new fork in the road. It's the primary decision point for the entire management pathway, and it completely replaces that old ruler on the X-ray approach. Now, you might be wondering, what exactly counts as minimal symptoms? Well, the BTS gives us a really clear definition. They say it's having no significant pain or breathlessness and no physiological compromise. So that's our benchmark, right? That's what we're looking for at the bedside. So this creates two very different paths. Path 1, the patient has no symptoms or just minimal ones. The recommendation, conservative care. And here's the kicker. Regardless of the pneumothorax size. I mean, that is a massive change. Now, if they are symptomatic, that sends us down path 2, where we have to start assessing for high-risk features. Okay, so let's say we're on path 2. Our patient is symptomatic. Now what? How do we figure out who needs us to step in right away, maybe a bit more aggressively? This is where risk stratification becomes absolutely crucial. All right, this is an incredibly high-yield slide. The high-risk red flags are hemodynamic compromise, hinting at tension, significant hypoxia, a bilateral pneumothorax, any known underlying lung disease, being over 50 with a big smoking history, or having a hemothorax at the same time. Just one of these is enough to make you think, okay, we need to consider intervention here. But hold on, before we jump in with a needle or a chest strain, there's a really important safety check. The guidelines are very clear. First, you have to make sure you can actually do the procedure safely. So what does safe mean here? It's pretty straightforward. On a chest x-ray, you need at least a 2-centimeter gap, either out to the side or at the top. Or if you've got a CT scan, really any size is okay as long as you have radiology support to help you get in there safely. It's all about making sure we don't cause more problems. Okay, so let's recap. Our patient is symptomatic, and we've confirmed it's safe to intervene. So what's in our toolkit? The new guidelines lay out the options really clearly, and it all comes back to that risk assessment we just did. Let's break this down. If your patient is symptomatic, but does not have any of those high-risk red flags, you've got a few choices. You could still opt for conservative care, use an ambulatory device, or try needle aspiration. But if they're symptomatic and they have those high-risk features, the choice is made for you. The recommendation is clear. They need a chest drain. And hey, it's worth taking a second to talk about these ambulatory devices. You might see things like the rocket pleural vent. Basically, they're a clever one-way valve system that lets a patient manage their pneumothorax as an outpatient. For the right patient, this is a real game changer. It can keep them out of the hospital altogether. So what happens if things aren't going to plan? What if the lung just won't re-expand? Or this keeps happening to the same patient? For these more complex cases, especially with a persistent air leak, the guidelines say it's time to think about getting the surgeons involved, something like a VATS procedure. All right, let's move on to the last piece of the puzzle, and it's a really crucial one. What do we tell our patients when we send them home? This discharge advice is so important for preventing this from happening again, and yeah, it comes up on exams all the time. First up, smoking, and the numbers here are just wow. A male smoker has about a 10% lifetime risk of a spontaneous pneumothorax. For a non-smoker, It's 0.1%. That is a 100 times greater risk. That's an incredibly powerful number to share with a patient when you're talking about quitting. Okay, here's another huge practical change: flying. The old advice was super restrictive. You had to wait 6 weeks. The new 2023 guideline? It's just 1 week after a chest x-ray shows everything's resolved. I mean, that is a massive quality of life improvement for our patients. But while the flying advice has relaxed, the advice on scuba diving has not. It's still incredibly strict. The bottom line from the guidelines is that diving should be permanently avoided. There is this one tiny, super specific exception, but let's be real. For pretty much every patient you see, the answer is a hard no. So let's wrap this up. What's the big takeaway? The 2023 guidelines are really pushing us all to be better clinicians, right? To treat the patient sitting in front of us, not just the x-ray. But that also leaves us with a really important question to think about. As we move to this symptom-first model, which relies so much more on our clinical judgment, how do we make sure that judgment is sharp enough to keep our patients safe? Especially that tricky patient with a huge pneumothorax who tells you they feel totally fine? That's the new challenge, and it's one these fantastic new guidelines have given us all to think about.